Thanks, Larry. Thanks for the invitation to speak today at this morning's rounds. So I'm going to go over what's new in MRI, the GU system. And it's been a few years since I kind of gave this lecture, and since then several issues have come up. One particularly is not so good, and that's the issue of NSF, which I'll briefly cover and review. And then afterwards, what I'll do is go over the state-of-the-art imaging as it applies to various organs of the GU system, while along the way I will show you some of our new techniques, such as contrast-enhanced subtraction imaging, our new techniques for MRU, where we use hydration and Lasix to stem the collecting system. We'll talk a bit about dynamic contrast enhancement, which is available, but with the new 3T magnets, we can really scan much faster and even get more perfusion-like data. And then we'll move on to diffusion-weighted imaging and see how it can help in particular issues such as localizing prostate cancers, and touch a bit on 3T Tesla. So we'll just review the advantages of MRI. As you know, it's non-ionizing radiation technique, and it is safe in patients who are allergic to iodinated CT contrast. You can give gadolinium. There's no kind of cross-reaction. There are several disadvantages, though. As you know, it's time-consuming. It could take up to half an hour to an hour to do an MRI, whereas a CT can literally take seconds nowadays with the multi-detector scanners. It is a costly examination in comparison to CT and the other modalities. Certain patients aren't able to have an MRI for certain implantable devices. The list has come down these years. The absolute contraindications nowadays are pacemaker leads, whether you have the pack in or not. If you have residual leads, that's still an absolute contraindication. And a Swan-Ganz catheter is an absolute contraindication, as well as metallic foreign body in the orbits is absolute contraindications. Other implantable devices, certainly new ones like neurostimulators, cochlear implants, they're all pretty new, and most of them are MRI compatible. We just need to know the make and model to ensure that it is safe. We have a manual that we look up these implantable devices to determine whether it's safe or not. If it's not in the manual, we need to contact the manufacturer to confirm. But most patients, when they get implantable device, they also get a sticker, a label, a serial number, make and model, and it should tell you on that little label, the sticky label, whether it's MR compatible or not.
Silvia, sorry.
Yes?
Current status of pregnancy?
Pregnancy, you can have an MRI. It's just the issue of gadolinium. We tend not to give gadolinium unless it's deemed necessary. In most cases with pregnant women, you can have the MRI and get by without gadolinium. Our most common indication in terms of body imaging is chorioappendicitis, and we do that without contrast. Certainly it's safe in second and third trimester, because that's when they actually also do fetal MRI, looking for congenital and fetal anomalies. The first trimester is questionable. So far there is no harm, as we are aware, for the first trimester. But for first trimester scanning, we still need written consent from the patient, and basically consent states that we are not aware of any known harm to the embryo at such an early stage. And most patients consent to it. So a new issue that's come up since I was last here talking about MRI, the GU system, is nephrogenic systemic fibrosis. So I'm just going to review this briefly, and then we'll move on to the new MRI techniques. So what is it? It's basically a mostly systemic fibrosing disorder, and the primary manifestation is in the skin. But it's known to affect other organ systems such as lungs, skeletal muscle, heart, diaphragm, esophagus, and meninges. And because of that, it can be quite a debilitating disease, and also can be potentially a fatal disease. So far, it's only been described in patients with renal insufficiency, severe renal insufficiency of grade 4 and 5, basically GFR less than 30, and patients who've also been exposed to certain gadolinium contrast agents. So just to give a bit of a brief background, it was first described by pathologists termed nephrogenic fibrosing dermopathy because it involved the skin. It caused patients in end-stage renal failure to have skin thickening and induration. Subsequently, in autopsy studies around 2003, they found that it involved extracutaneous structures, as already mentioned on the previous slide. In 2006, there was a link that these patients also had exposure to gadolinium contrast dye, and that was implicated in the pathogenesis. Just so you're aware, it is a very rare disease, and the numbers It's hard to get the exact number because we are still acquiring data because it's a relatively new entity. Initially, it was quoted that maybe up to 5% of patients with severe or end-stage renal failure may be affected with NSF, but now the numbers have really come down, possibly because of the awareness of this. Unfortunately, it's also potentially fatal, and exact numbers are not known, but it's believed to be less than 1% of the patients that are affected with NSF. So far in Canada, there's only been 3 known cases and only 1 locally in VGH. There have been no deaths so far in Canada due to NSF. In terms of worldwide cases, there's been over 315 registered cases based on the website as of the last update, March 15, 2009. So the exact pathophysiology is unknown, and more importantly, the cure is also unknown. So the best part right now is prevention of this disease. These patients may have a clinical partial response. They may respond a little bit to renal transplantation or hemodialysis, but those are not confirmed treatment cures. Okay? So
the risk increase as the GFR drops.
that's the theory that perhaps the more impaired the renal function is, the higher the risk. The higher the dose of gadolinium you give, the higher the risk. Gadolinium, one of the proposed pathogenesis is free gadolinium is considered toxic when it's not chelated to the agent. And in people who have normal renal insufficiency, the gadolinium is literally cleared within 24 hours, whereas patients who have renal impairment, it just may take days to clear it. So they've got this free gadolinium floating around. And the other proposed pathogenesis is the circulating fibrocytes. And they feel that with impaired renal function puts them at risk for developing NSF. This is just proposed pathogenesis. So clinically, the symptoms can develop as early as 2 days after GAD injection or even up to 18 months. They can present with rapid onset of fluctuating hypertension and present with skin tightening. The skin manifestations can be seen as firm erythematous indurated papules. They can coalesce into plaques. You can get pot-orange appearance, and a brawny discoloration. Mainly involves the extremities, but can involve the trunk as well. It can be debilitating. It can cause flexion contractures, which limit range of motion. You get pain, paresthesia, and weakness as a result as well. The diagnosis is made from a skin biopsy of the affected region. Basically, you see thickened dermis. You're going to see more collagen than usual, fibrosis of the septa. It's not a malignant entity. And basically, one of the classic features is the circulating fibrocytes, which is proposed in the pathogenesis. And this is a patient, bone scan on your left and MRI on your right, showing a case of NSF, where you can see uptake of the muscles or the soft tissues within the lower legs, thighs. And on the MRI, you can see that there's diffuse infiltration of the subcutaneous fat with all this fibrosis. So I already mentioned the proposed pathogenesis. Basically, it's patients in renal insufficiency, basically GFR of less than 30. Certain gadolinium agents, the ones that are less tightly bound to the chelating agent, so there is more free gadolinium floating around, and circulating fibrocytes. Certain additional conditions may kind of aggravate the situation or put them at higher risk for developing this, such as kind of pro-inflammatory type conditions like thrombosis, ischemia, that sort of thing, and even liver transplantation has been implicated as a possible cause as well, in addition to the factors of renal insufficiency and administration of GAD. So as mentioned, certain gadolinium contrast agents are implicated in NSF. And as mentioned, these are the ones that are less lightly chelated, OmniScan, Magnevis, and Optimark. We were using OmniScan, which is why there was one patient locally that's been affected with NSF. Fortunately for us, at the time NSF was coming, our contract with OmniScan was finishing, and we were trialing multi-hands, so it was kind of fortuitous for us that the timing was right, that we were basically done with OmniScan and we moved on to multi-hands, which has not been implicated in NSF so far. So as mentioned, the more tightly chelated agents, so far there have been no known cases of NSF, and that's multi-Hans, ProHans, Vasofist, and Gadofist. We're currently using multi-Hans, because there's no known case of NSF, and also one of the reasons we like multi-Hans is we can actually use half the dose and yet still get good results, so it's more cost effective. And also multi-Hans has another property that helps us characterize liver lesions and assess the biliary tree, because it is also taken up by the hepatocytes because it serves two functions for us. So what to do in these patients with renal impairment? There are various advisory boards out there, and we're still collecting data, so the policies could be changing over time and recommendations. They're not, set hard and fast rules. They're just kind of guidelines to kind of help you along the way. Just remember, just tailor each case to the individual patient and determine risk versus benefit to administering gadolinium. So basic guidelines, basically, if a patient has impaired GFR of less than 30, you have to weigh the risks and benefits of giving GAD and discuss this with the referring physician. A nephrologist may be involved, usually involved if the renal impairment is that severe. For patients grade 3 impairment, GFR of 30 to 60, the risk of NSF is extremely low. We don't require written consent. We don't discuss the risk of that to the patient. We basically just order the GAD if we deem it's necessary. For patients with severe renal impairment grade 4 and 5, GFR of less than 30, if we feel that gadolinium is necessary for examination, we require informed written consent. And for those of you who want to look at the actual consent form, it's on our website, www.vanrad.org. You could download or print out that consent sign. It's nice to kind of give it to the patient ahead of time so they can have time to kind of think about it to see if they want to undergo this procedure. So far in abdominal MR imaging, I haven't had to ask a patient for written consent. Most of the time we can get by without contrast, because with T2 alone, images on T2 alone, you can kind of, depict the pathology and kind of figure out if the lesion is a simple cyst or very complex. And at least with MRI, it's non-radiating, so you can actually do frequent scans as follow-up. At least you kind of got a baseline. So that's kind of a brief synopsis of NSF, and for those of you who want more information, there are a couple of websites. We have the NSF Advisory as part of the Canadian Association of Radiologists. That's their website. And for those of you who want to know more information on an international basis, there's a website by the International Council for Nephrogenic Fibrosing Dermopathy Research, and there they'll list the current cases worldwide. Okay, so now that I've kind of scared you into ordering MRI, I'm just going to go over some of the MRI techniques that are available that are new. As I go through them, I'm also going to go systematically through the GU system, kind of give you kind of state-of-the-art current imaging where we're at with MRI and any of the new techniques that may be helpful. In terms of adrenal imaging, trying to characterize versus whether a lesion is adenoma or not, CT actually does quite well. You can characterize the lipid-poor adenomas with washout, but certainly a Hounsfield unit on CT of less than 10 is diagnostic for adenoma, and you can pretty much stop there. So the role of MRI in characterizing whether incidental adenoma is an adenoma or not isn't as common as it used to be. But certainly if you incidentally have a patient with an adrenal lesion, you can quickly do in and out of phase imaging, which will depict microscopic fat, which is a feature in adrenal adenomas. So in this case, on the in-phase image on the T1, you see an adrenal nodule, a right adrenal nodule. You basically just do an out-of-phase sequence, which basically exploits the microscopic fat within the lesion and basically becomes dark. So that's classic for an adenoma. But as I said, nowadays CT can make that diagnosis as well. Where addressing an adrenal lesion might come in helpful is that in a pregnant woman, this woman 29 weeks pregnant, she had complications with the pregnancy with basically hypertension and other issues, choreocoagulation sort of issues, and she was put on anticoagulants and developed some pain, had an ultrasound. They weren't sure if it was a hematoma or what was going on. They saw a perihepatic lesion. So she came to MRI, and basically with MRI on the T1 sequence and the out of phase, we didn't see any signal dropouts, so we knew it wasn't classic for an adenoma. We didn't see that the lesion was bright, and for some of the residents who are taking the boards, for MRI on T1, you want to see the lesion is possibly bright, because if it's bright, it would indicate macroscopic fat, hemorrhage, possibly proteinaceous fluid within a cyst. gadolinium if contrast was given. Occasionally calcification can be quite bright. So as you see on the T1, it's not typical for a hematoma, which they might have suspected based on her treatment of anticoagulation. But on further history, she actually had hypertension, which was long-standing. She actually had a 20-year history of hypertension in a 20-year-old patient, in a 40-year-old patient. So we suspected it was probably a pheochromocytoma. And sure enough, when they did the urinalysis, it was 20 times normal. So this was a pheochromocytoma. And pheochromocytomas on MRI, some people describe it as a really bright lesion, and it's bright if it's cystic. But unfortunately, it's not specific. You still need to go with history. So history is a clue because this is another case of a pheo, and the differential could be here of a complex metastasis that has solid and cystic components, as shown here. And even a primary adrenal cortical carcinoma is also in the differential. So in terms of using MRI to differentiate, it can be sometimes non-specific. And certainly for pheo, you really need the history as the clue. So here's T2, you got solid and cystic components. T1, again, what's bright on T1 is probably hemorrhage in the lesion. Pheos are prone to bleeding. And then post-contrast, you could show the vascular solid component and the non-enhancing cystic component. Another case of a pheo, this was possibly thought as maybe a cystic met. It's very cystic looking, or a necrotic met, or even a necrotic primary adenoma, because she actually clinically didn't have symptoms of pheo. This was actually a non-functioning pheo, and that's, as I mentioned, history is quite important. Okay, moving on to kidneys. MRI is helpful in patients who are allergic to iodinated contrast. It can help in the evaluation of complex cysts, such as hemorrhagic cysts and RFA follow-up. And I'll show you an example of the complex hemorrhagic cyst, where subtraction imaging can be very helpful to determine if there's any enhancing components. MRI can be helpful in staging of renal cell carcinoma. And even without contrast, you can actually use various sequences, such as a GRAS sequence, to see if there's thrombus in the renal vein or IVC. And I'll show an example of that. First case is an angiomyolipoma. MRI has advantages in that it can identify microscopic fat, like I showed you in the adrenal adenoma case, but it can also identify macroscopic fat with certainty, because you can use the fat suppression sequences to confirm the presence of fat. So here in the image here, you've got a mass in the left kidney, and again, it's bright on T1, so you're thinking it's a hemorrhage or fat, high up in your differential. On T2, the lesion remains bright and it matches the signal intensity of the retroperitoneal and subQ fat. When you apply the T2 fat sat, this lesion totally suppresses and matches that of the saturated fat. So this is a fat-containing lesion in AML. This is a patient with extensive polycystic kidney disease that also involved the liver. So simple cyst, classically bright on T2 and dark on T1 with no contrast enhancement. That's the appearance of a simple cyst. So here you can see that the cysts have completely replaced both kidneys, pretty much the entire liver. Here is the left lobe wrapping around the spleen, which is not involved. Axial image full of cysts in the liver, kidneys, and perhaps even in the pancreas here. And here's a splenic vein heading to the portal vein confluence. So that's the appearance of a simple cyst. And here's a case where MRI was helpful. This is a 50-year-old male, happens to be a physician. Can't remember why he had the ultrasound to begin with, but it found a complex cyst in the left kidney. As you can see, there's a nodule in here that could be soft tissue, or possibly could be a blood clot within a hemorrhagic cyst. You can see some low-level internal echoes, so certainly it's not a simple cyst. He was scanned again with an ultrasound. We tried to move him around to see if this could be a mobile blood clot, but it was persistent. So went on to CT. Non-contrast scan. It shows that the cyst is quite dense, and it's probably some sort of hemorrhagic cyst, but we haven't really accounted for what's going on with that nodule. Post-contrast, we still can't identify the nodule, but it was still there on the ultrasound, so we went to MRI to further sort out what was going on. So on the MRI, as you can see, it's not a simple cyst because it's not bright on T2. And on T1, it's not a simple cyst because it's bright on T1, so you're thinking, is this a hemorrhagic cyst or a cyst with proteinaceous fluid? When you give contrast, it's hard to say if this cyst enhances because it was bright to begin with. And that can be a dilemma when you're dealing with lesions that are bright to begin with on T1. you give the contrast, is it enhancing or not? And basically what you can do is subtraction imaging, which is one of the new techniques. So what you do is subtract the non-contrast from the contrast image. Anything that doesn't enhance with contrast will stay black because you've subtracted it. Anything that's kind of gray to white will be varying stages of enhancement. So in this case, we subtracted the image, and you can see that the cystic component stays black, and that soft tissue nodule actually enhances. So we know this is enhancing soft tissue cyst. This has to come out, although it doesn't look overtly malignant, and it turned out to be a papillary adenoma. And similarly for RFA cases, they can look like this. Post-RFA, they're kind of not that bright. They're bright on T1. How do you know if there's residual disease when you give contrast? And we do a lot of subtraction imaging with our post-RFA cases to look for any residual disease. This is another case on ultrasound where we see a cyst, and then we see this kind of area that's a little bit more echogenic than the adjacent normal parenchyma. You can see displacement of the vessel, so there is mass effect. He couldn't have a CT for contrast allergy, and then we do the MRI. We can see that this is a solid and cystic looking lesion. We know it's complex, and this ended up being a renal cell. The same lesion, enhances with contrast and shows a bit of washout on delayed images. Interestingly, that lesion looked like a fairly simple cyst on ultrasound, but yet on MRI, that adjacent cyst actually is a hemorrhagic cyst, classically dark on T2, and was bright on T1 and didn't enhance with contrast on the subtraction images. So moving along, you can see renal cell carcinomas even without contrast. This is a cystic renal cell in a patient who has a renal transplant. You can see the atrophic native kidneys and complex solid and cystic components. It does enhance with contrast, just to show that. Pre and post, you can see how vascular the lesion is. Renal cell carcinoma, you can also extend for tumor thrombus. Usually on a T2 weighted image, the vessels should be dark. Here you can see the IVC is not dark, it's distended with this, soft tissue intensity, and there's a tumor in here in the right upper pole, thrombus in the renal vein extending into the IVC, and you can follow the superior extent. This is a graph sequence done without contrast. You can see the vessels are bright, the patent vessels are bright, and you can see that the IVC is not bright, so that's thrombus. Okay, so you can use kind of non-contrast techniques to even look for tumor thrombus. Quick thing on MRI, you can use it for renal donor evaluation and assessing for renal artery stenosis. Certainly in younger patients where you want to save the patient radiation, you could use MRI. For renal artery stenosis, it is a bit of a problem because in this patient population, they have renal impairment, and you want to give the gap, but you can't really, so what do? Right now, in terms of new techniques, people are looking into non-contrast MRA studies. So that's coming up, and hopefully that will be useful in this patient population. So here is a normal MRA showing normal renal arteries with no evidence of stenosis. Here's renal artery stenosis confirmed with angiography, and a stent was placed across the lesion. Another case of MRA in a transplant patient showing renal artery stenosis. You just can't see the origin right here. Okay, moving on to MR urography. There are 3 ways to do it. You can just use T2 weighted sequences, and using T2 weighted sequences looking for hydronephrosis or filling defect, and you can use Fiesta, which are kind of the cine loops, to kind of watch the peristalsis move along. It's almost like similar to a fluoro guided study where you can dynamically assess the structures. So these 2 sequences would be safe in pregnancy if you've got a woman with cruri, hydro, and you're wondering if there's actually true obstruction or if it's just due to her pregnancy. And you can also give contrast to look for filling defects. To improve the technique, improve visualization, you really need to distend the collecting system, and we give Lasix and hydration, similar to what we do for CT-IVPs. So the case on your left here, basically, when the patient's obstructed, it's pretty easy to see the collecting system, but when the patient's unobstructed, it's really hard to really see the calyces quite well, especially in a hematuria workup. So when you distend the system, you could definitely see that it's much easier to interpret the collecting system here. Okay, and in terms of the cine loops, this is what I mean by one of the cine loops. Here's the right ureter coming down, but you don't see it in full view. What you can do is just kind of scan over time, and you can see kind of opens up and peristalsis. Okay. And then just for completeness, this is the post-contrast. You can see that there's good opacification of the collecting systems with no filling defect identified. All right, and then one of the advantages of MRU is you can actually assess beyond a level of obstruction. Here, a patient who had bilateral retrograde studies, you can see kind of classic irregular filling defect here in keeping with the TCC. Yet on the left side, there was complete obstruction, yet we weren't able to analyze what was beyond it, and we didn't know the extent of involvement on the left side. Whereas MRI, you can visualize the entire system. And on the right side, you can see this chronic hydro compared to the left, where you've got atrophic right kidney. And there is the TCC on the right side correlating to the retrograde study. On the left side, you notice that the disease is extensive. So that was helpful in this case because he basically had a nephrourethry on the right side and had an implantation on the left side, given that the disease wasn't extensive on the left side. Okay, and just post-contrast for completeness, you can see that there's chronic obstruction on the right side, there's lack of contrast filling the collecting system, so you know this is pretty high-grade chronic obstruction, whereas on the left side, even though you have hydro, you still see some contrast in the collecting system. And post-contrast showing that there's filling defects within the ureter on the right side. Other thing that's helpful with MRI is also in terms of staging bladder cancer. Oops. You can stage local disease here, this irregular thickening. We don't see any lymphadenopathy. And he also has a synchronous tumor that was unknown, so he's got this big papillary TCC also in the right collecting system, shown here on T2, and it shows some contrast. Quick thing about MRI of the scrotum, it can be helpful in equivocal cases clinically. This was actually a 56-year-old lawyer who came in with basically an acute scrotum. On ultrasound, it showed some hypervascularity. We thought maybe it could be orchitis, but it just looked a bit mass-like, and we thought, oh, is this an abscess that we're dealing with? So we went to an MRI. He didn't really improve dramatically with a course of antibiotics, so within a week we had him in the MRI. And here, post-contrast, we see an enhancing mass. We know it's not hematoma, because hematomas don't enhance. We know it's not an abscess, because usually they demonstrate rim enhancement. This is solid homogeneous enhancement, and this was proven to be a seminoma. Undescended testes can be helpful. As you know, the testes is normally quite bright on T2, so you can use this to kind of identify undescended testes if we can't find it clinically or on ultrasound. This is a case where the left testis is undescended and has a large seminoma sitting in there, coronal plane, and this is the axial plane. Okay, and this is just a case of lymphoma where on MRI you can show the extent of the disease, infiltration of the right testes with grossly enlarged spermatic cord right in there, and showing contrast enhancement. Okay, moving on to prostate, and what I'm going to do is kind of cover diffusion and 3 Tesla and finish off with that. So basically, when you do a prostate exam, you can do it with an endorectal coil. This is what they look like. This is a 50 cc syringe, just to give you a relative size of the coil. So this is basically the balloon that's inserted, deflated. This side is applied to the prostate gland. And then once that's put in, the surface aroya coils are also applied to the patient, and they get their MRI. So just to show an example how when you use a coil, you do get improved visualization of the prostate gland. So this is without the coil, and this is with the coil. You can see the exquisite peripheral zone here is homogeneous right on T2, and that's a normal prostate gland. You can see here this is the transition zone and central zone. On MRI, we can't differentiate the transition zone from the central zone. We call it collectively the central gland. Okay, so T2, axial and coronal images showing the normal peripheral zone, which I said is homogeneously bright on T2. Prostate cancer is actually low signal on T2, so fairly easy to see in the peripheral zone. And you can see how it can be tough to identify a prostate cancer in the transition zone because it's not very bright, and the cancer could kind of blend in there. So there is a limitation in trying to analyze for prostate cancer in the transition zone on T2 alone. So prostate cancer is dark on T2. Unfortunately, it's not specific, and that's why you can't use T2 MRI as just a standalone technique for diagnosing prostate cancer. At this point, we still need the biopsy to confirm. There are other features that can demonstrate low T2 signal, and that's post-biopsy hemorrhage, post-radiation, hormones, and even prostatitis and dystrophic changes can look like cancer. And that's why we're trying to, look at other techniques to help be more specific in helping diagnosing prostate cancer. BPH can be a bit of a problem because you can kind of compress the peripheral zone. It does make it a little bit harder to interpret. And just showing a case of prostate cancer in the left midgland here, where it's spread beyond the capsule, and classically that's where we look, is where the neurovascular bundle is, and usually that's where the cancer spreads to that little defect of the capsule. So here you can see that the tumor is spread beyond here with an irregular outline. So this is T3 disease. A case where there's seminal vesicle invasion. Seminal vesicles tend to be normally bright, so these are normal seminal vesicles here, bright on T2, and here you can see they're invaded by tumor immediately as they become dark. Not only that, this patient also has lymph nodes. So with MRI, you can do local staging. As mentioned, with the new techniques now, you can do dynamic contrast where you can image the prostate gland so quickly that you can see what's happening in terms of enhancement of the tumor or of the gland. In this case, this is a patient who has a tumor in the left apex here. And basically, with prostate cancer, most of them will show early enhancement compared to the regular prostate gland. As shown here, just keep your eye on the left apex so you can see that kind of lit up quite quickly. So that would be in keeping with, that correlates with the site of cancer. Oops, I'm frozen here. All right. And because of that, because we can, examine the prostate gland with contrast over and over repeatedly in such a short time frame, you can actually do pharmacokinetic curves, which is what we've done with some patients on the 1.5 Tesla. And we've shown that prostate cancer basically enhances earlier and enhances more than normal peripheral zone. So let's move on to diffusion-weighted imaging. It's a new technique in body imaging. It's actually been around for almost 20 years, but it's mainly used in neuroimaging because usually the brain doesn't move as much as the abdominal structures. But with improvements in MR technology, we actually can now use this technique in the abdomen. So diffusion-weighted imaging is based on random motion of water molecules within extracellular, intracellular, and intravascular spaces. And MRI can detect this motion. So basically what the theory of diffusion is that water molecules, if there are more cells such as in tumor, or if there's viscous fluids such as an abscess, the water molecules are not going to move a greater distance as they normally would in normal cellular tissue. So you can actually find areas that have restricted diffusion that could indicate tumor or perhaps even infection. So here's a patient who has tumor in the left apex, and on diffusion-weighted imaging, there's two sets of images you can look at. You can look at the diffusion-weighted image alone, or you can look at the ADC map. So on the diffusion-weighted image alone, restricted diffusion is bright. The problem with the prostate gland is the peripheral zone is already bright, so the tumor can be masked in the diffusion-weighted sequence. And that's why we use the ADC map, because on the ADC map, the diffusion is actually dark. So when we're looking for restricted diffusion, we tend to look at the ADC maps and not just the DW images. So here on the ADC map, you can see that the tumor is dark. So that's an area of restricted diffusion, correlates with the site of cancer, which is biopsy proven. Another case where we don't see any obvious tumor in here, it's kind of heterogeneous, but you don't see any mass effect. And again, you don't see it well in the diffusion image, DWI, but on the ADC map, you can see an area of darkness. So that's where diffusion was helpful in detecting a cancer that we couldn't see on T2 weighted image alone. So what about the transition zone? I told you transition zone is a bit tricky on T2 weighted images alone because it's darker than the peripheral zone. It's going to be similar signal intensity as cancer. So if you look at this patient with a high PSA and negative biopsy, you don't see an obvious tumor in the peripheral zone. Mind you, it's not very bright, but you just don't see a focal lesion in there. So when you do diffusion-weighted imaging on the DWI, it stands out as bright because the normal transition zone is not bright. So it does stand out on a DWI. And on the ADC map, it's dark. So in this patient, diffusion was able to find the site of cancer that we were able to prove. And not only that, it was able to kind of give an estimate that this is a pretty large tumor in the anterior transition zone. Another case, a PSA of 54 and negative biopsies. Again, nothing really obvious in the peripheral zone. And then on T2, you wonder about this area here. It looks a little bit different from the rest. So on the diffusion, not that obvious in the DWI, but on the ADC diffusion map, you can see that that area is dark. So we're able to target that lesion and do the biopsy. So what's new and coming now is basically trying to fuse the MR image with the ultrasound. So when you're actually doing the ultrasound guided biopsy, you're biopsying that MRI abnormality in question. Because as we detect smaller lesions on MRI, it can be a bit equivocal as to whether you're really hitting that lesion on ultrasound. I mean, now we're diagnosing the other case, we saw a lesion that was about 4 millimeters. And that may be hard to locate on ultrasound biopsy, but if we have a fusion program, then we can say for sure that's it, we've hit the lesion. So that's where research is going in this area, because with MRI now we're finding these small tumors that we can do focal therapy. If we're going to do focal therapy, we have to know we're hitting the lesion dead on. The other thing with diffusion is not only can you get qualitative assessment by looking for areas that are dark, you can also get objective measurements, ADC values as they call it. So for the peripheral zone, the ACD values are higher than in cancer, and they're higher than that of the normal central gland. So basically, cancer's restricted diffusion has low ADC values compared to normal tissue. And if you can make objective measurements, then you can also use this technique to basically monitor treatment response objectively. And this is what we've shown and published, and similar people have also shown similar results. Basically, cancer will have lower ADC values. Also, in correlating with Gleason scores, with so far the number of tumors we have on our 1.5 Tesla scanner, there is a general trend that the higher the Gleason score, the more restricted the diffusion is. And this is something we've worked on the 1.5 Tesla, obviously, with Dr. Goldenberg and Dr. Ted Jones and Dr. Peter Kozlowski and myself. We've actually now moving on to doing the same thing on the 3 Tesla magnet out at UBC. So just finishing off with the 3 Tesla MRI. Basically, the higher the magnet strength, you're going to get better pictures. It's like going from regular to high definition TV. The pictures will be crisper. Okay. And then you can also acquire the images faster. So when you're given contrast, you can scan so quickly and really get really good pharmacodynamic data on normal and prostate gland cancer tissue. Just keep in mind that when you ramp up the power by 2, you're also depositing more RF power on the patient by a quadruple amount. Basically, what's called specific absorption rate. MRI is safe. There's no ionizing radiation, but the higher the power, the more strength, they could actually feel the warmth. They may feel warmer on the 3 Tesla scan, but 3 Tesla is still considered clinically safe. When you go into a higher magnet, you're prone to more artifact. And also, when you go to a higher magnet, you can't just really plug in your 1.5 Tesla programs. You have to kind of reprogram your TR and TE and basically reprogram all your protocols. Okay. So in terms of coil and without coil, it's been shown that if you use a 1.5 with a coil and compare that to a 3.T without coil, you're getting equivocal results. So that's the advantage of 3T. You actually may be able to scan patients without a coil, which the patients really prefer, because the patients really don't like the coils. They don't really like lying there for 45 minutes with a coil inside. They actually prefer the prostate biopsies. I've asked every single patient. They say they'd rather, they actually prefer the biopsy than the MRI, just because the biopsy was much quicker than lying in the magnet for 45 minutes. So if you can get good pictures without the coil, then that's really ideal for the patient. So here's 1.5 with coil. There's 3 Tesla without coil. Again, without coil, and this is 3 Tesla with a coil. And you can see, of course, if you're going to use 3 Tesla and you're going to use a coil, you're going to get much better pictures than without the coil. So that's where we're at right now. We're doing some studies with 3 Tesla with the coil. You can see how much better the picture is. It's really crisp in terms of the outline of the prostate gland. You can see there's a tumor here in the right mid gland. On diffusion, ADC map, it's restricted diffusion, it's dark. Post-contrast just gets you a sense of how quickly you can see it, and the images seem quite crisper. And this is just a comparison. Top row is the 1.5 Tesla patient, and the bottom row was a 3 Tesla. You can see on T2 images, it's much more pristine. Same on the ADC map. You can see better resolution of the lesion, and same with the post-contrast as well. Just another patient, again, in the left apex, just showing you post-contrast diffusion in T2 weighted images. Okay, so in terms of comparing results, we looked at diffusion alone, contrast alone, combination of the both. Of course, if you're going to use a combination, you're going to get higher sensitivity, though slightly lower specificity. On the 3-point Tesla magnet, so far with 25 patients, we can actually get on basically 100% specificity using the 2 techniques. So what a lot of people are doing is what's called multi-parametric scanning. You might have heard of that term. So they're using T2, diffusion, and contrast. They're using all 3 in combination to basically increase their sensitivity in picking up prostate cancer. So that pretty much brings me up to the end of my talk. So in terms of MR imaging, basically ultrasound and certainly CT is the workhorse. IVP is basically on its way out. In terms of workup of stone disease and hematuria, CT, KUB, and CT IVP have basically replaced it. MRI is helpful as a problem-solving case if CT doesn't solve the question, or if you want to avoid radiation, perhaps in young or pregnant women. Certainly with subtraction imaging, you can evaluate complex cysts, hemorrhagic cysts, RF-ablated lesions. In terms of future directions, diffusion-weighted imaging is basically a functional technique. You can see that you're looking for areas of restricted diffusions. So MRIs move beyond the morphologic stage into more functional anatomy where you can assess perfusion and diffusion. So there's constant refinements in these techniques. Now companies are working on non-contrast MRA techniques because of the whole NSF issue. So it'd be ideal in the diabetic patients where you're looking for runoff and calf disease. It's nice to get a non-contrast MRA in these patients. As mentioned, ultrasound MR fusion to aid in prostate cancer diagnosis and treatment. MRI-guided biopsy, it's out there, but it takes about an hour and a half to do a whole biopsy. So that's why ultrasound MR fusion is probably more feasible and practical approach. But people are still at it, still trying to, cut down their MRI biopsy time and looking at ways to do MR-guided focal ablation. So with that, I thank you for your attention.
Great, thanks.